topic is insulin and diabetes in pregnancy. So first thing is when to initiate insulin therapy. So we all know that when a pregnant woman is diagnosed as diabetic or as a gestational diabetic, or if she is previously diagnosed as a pre-gestational diabetic, so in the situations are different. So a pre-gestational diabetic is already on treatment, who is aware that she is diabetic. The other situation is when she is a gestational diabetic and diagnosed first time during pregnancy, and at this stage she may either be a GDM or she may have been a pre-gestational diabetic which she was not aware about, and that situation is called diabetes in pregnancy. So we will talk about both the situations, that how the insulin has to be given, in what doses it has to be given, and what are the precautions we have to take. So first of all, what are the indications of insulin therapy? So the different societies have given their guidelines. So the FIGO in 2015, their guidelines were released. So it says that diagnosed, diabetes diagnosed before 20 weeks and after 30 weeks of gestation, insulin therapy should be given. Fasting plasma blood glucose above 110, 1 hour postprandial above 140, and weight gain of more than 12 kg. Then the ACOG and the ADA, they say that first line therapy if glycemic control is not achieved after diet intervention. So 2 weeks of medical nutritional therapy is what is advocated in all diabetics when we first diagnose them in pregnancy. I think all of us are following that. So after that, some of us may want to give oral hypoglycemic agents and some of us give insulin. So the guidelines say that if the pregnancy is in the first trimester or before 20 weeks, even our Government of India guidelines say that if the pregnancy, the diabetes has been diagnosed before 20 weeks, we should go for insulin and not for the oral hypoglycemic agents. That is the one which is advocated at the moment safely with the maximum evidence is the metformin. So diabetes diagnosed before 20 weeks of gestation, and if the blood sugar is not controlled with the maximum dose of metformin, that is 2 gram per day, insulin should be added. This is our Government of India guidelines. So if you have given the metformin to a woman who is more than 20 weeks and maximum dose, you start with 500 milligram twice a day, then you step up to 1 gram twice a day, but that is the upper limit. After that, if she is still not meeting the targets, you have to add the insulin. So other indications for insulin in diabetic pregnancy are the FGR babies and those at risk of preterm birth. So this is some new evidence coming up that those who are FGR already, if we give metformin, they may have a lower birth weight. So it is now coming in many of the new evidences that we should not give metformin if already the baby is growth restricted or the women are at a risk of preterm birth. So previous preterm deliveries if they have had, it's much safer to give insulin in such women. And anyone with already a macrosomic baby or polyhydramnios, that is also a relative indication of starting insulin. Then any diabetes with organ dysfunction, we should not be giving the oral hypoglycemic agents. So here it is always insulin, and of course it is the treatment of choice if there is a diabetic ketoacidosis. Then if the patient is being given steroids for fetal lung maturity, so we all know that the sugars can spike, and at this time we may have to give insulin by the sliding scale. So the last one would be that during labor for a strict glycemic control, many of these women who are not on insulin in the antenatal period may require insulin. Now, which are the insulins which are safe in pregnancy? So there are 2 types of insulin. One are the intermediate or the long acting, and second are the short acting. So of the intermediate long acting, the NPH, that is the neutral protamine hagadol, this is a very, very old insulin And there is lot of evidence it is safe in pregnancy. It is also much cheaper than the long acting, that is the Detamir, which is available and which is also evidence says it is safe in pregnancy. But having the advantage of lower cost and large experience by the obstetrician, we all still prefer to use the NPH. Then the short acting are the regular human insulin, which is the cheapest and most suited for our setting. And then we have got the ultra short acting, that is the Lispro and Aspart, which are the insulin analogues. They are also absolutely safe in pregnancy and they have got distinct advantages, which I'll just tell you. But the cost is again the factor for them. So the data is limited for insulin glargine, which is a long-acting insulin, because of the greater mitogenic potential and the risk of macrosomia, which is mentioned in some of the studies. And then the declodic, also the long-term studies are not there. Rapid acting, the glulicine is also not well studied. And avoid pre-mix, that is the mixed start type of insulins, even though our national guidelines give those, but they are not ideal because normally we will not be able to achieve good glycemic control without causing hypoglycemia with these kind of pre-mixed insulins. So the basal insulins, again now when I'm talking of the types of insulin, I told you they are the long or intermediate acting and the short acting. So the long or intermediate acting are the basal insulins, which act over a longer period of time, and their mechanism of action is to suppress the hepatic glucose production, and they maintain a near normoglycemia in the fasting state. So the other is the pre-meal or the prandial insulins. So these are given during the meal time as bolus insulin injections, which cover the extra requirements according to the kind of food which is eaten. And of these, the types, again I told you, the regular, the Aspart and the Lispro, which are all safe in pregnancy. So if you see this table, you will see that the Lispro and the Aspart, they immediately, the action is very quick, 3 to 15 minutes. The action starts, the peak effect is within 1 hour and the approximate duration is 2 to 4 hours, whereas the regular insulin, the effect starts in 30 minutes and peaks in 2 to 4 hours and effect lasts for 5 to 8 hours. So what happens is that regular insulin is always advocated half an hour before the meal. And this half an hour period, sometimes patient may forget to eat her meal in time or she may eat it earlier. So it's very difficult, to control it. Whereas the Lispro and Aspart, they can be eaten, they can be administered along with the meal. So she sits on the table, takes her insulin and starts eating. So the advantage is definitely there. And then it also, blunts the hypoglycemia which can occur before the next meal. So you see that it acts, the regular insulin acts for 5 to 8 hours. So if the patient in between her 2 meals has not taken a snack, she is likely to have hypoglycemia before the next meal. Whereas with this 2 to 4 window, she will not have the hypoglycemia. So these advantages are definitely there. And if our patient can afford it, I would say we should go for the short acting, that is the Lispro or the Aspart. Then the NPH, the onset of action is 2 hours. It may take, a peak is variable between 4 to 12 hours. And it can act for about 8 to 18 hours, but normally we need to give it in a 2 injection dose, 12 hours apart. And the other long acting, which are the insulin glargine and Detamir. So I'll talk about Detamir because glargine we are not using in pregnancy. So again it is like insulin, the NPH, 2 hours for onset of action, 3 to 9 hours peak effect, but you can see that duration of action can extend up to 24 hours. So it is a longer acting and normally only 1 dose is administered of this Detamir. So the short acting, the human insulin, it is the least antigenic because least antigenic, and so the advantage is that the antibodies are not formed, and the transplacental insulins don't cross placenta, but the antibodies made against the insulin cross the placenta. So if you are not giving the human insulin but the bovine or porcine, which nowadays we don't use, those antibodies can cross the placenta. So that is the advantage, and however it has timing should be very good. It's very crucial, as I told you, half an hour before meal, and it can cause late hypoglycemia. And rapid acting, I told you the advantage. Now this also intermediate acting, I have already told you that the advantage of this. So now how do we calculate that, how much insulin is to be given? So if the patient is already a known case of type 1 diabetes mellitus, her, requirement of insulin over her gestational, as her gestational period increases, will increase from 0.7 units per kg in the first trimester to 1 unit per kg in the term. And normally in such patients, multiple daily injections, 3 to 5 are required to cover both the basal as well as the rapid acting for the bolus. So we have to remember that type 1 diabetes is an insulopenic state. So they require insulin for entire day to cover for the needs. And the other is the type 2 diabetes. Here the requirements during the first trimester are similar to those prior to pregnancy, but there is a rapid increase in the demand in the second and third pregnancy, because as the pregnancy progresses, the insulin resistance keeps increasing because of the placental hormones which are secreted. And in fact, the requirement may be much more than in type 1 diabetes in the term. So this particular study also I have quoted that it may be as much as 1.6 units per kg per day in a obese type 2 diabetic. So that is, the level of number of units which may be required. Now, how do we calculate that what is the total dose required in a pre-gestational diabetic? So there are two strategies. One is the weight-based and one is the carbohydrate counting. So if you see the weight-based strategy, it can be used to estimate the insulin requirement. So each, how you divide pre-meal dose is approximately 0.15 times the current weight, and the total basal dose is calculated as 0.45 times the current weight in kg. So now for instance, if a woman is 80 kg, each preprandial dose will be 0.15 into 80, which is 12 unit, and total basal insulin over 24 hours which will be required is 0.45 into 80, which is 36 units. And if you are using NPH, you will divide it into 2, so 18 and 18. So this is the, normally what I tell my students, you may start at a much lower dose, but gradually when you finally find that your patient has achieved the targets, this will be the dose, which will be required. So you can from the beginning calculate and keep it, and know that gradually you have to go up to say these number of units, 36 plus 12 into 3. So that is the amount of insulin which she may be needing every day. But we normally will not immediately start it in this highest dose. It will always be gradually titrated. Then the other method is the carbohydrate counting. So carbohydrate counting, we know that roughly 1 unit of insulin can neutralize 10 gram of carbohydrate in the first half of pregnancy. So in all the packets which are sold, normally they write that what is the carbohydrate count. So carbohydrate count, one carbohydrate count has 15 gram. So if the patient is taking 1 serve of carbohydrate, that is 15 gram. So that is how patients can actually be, in at least in the Western countries, they see how much carbohydrate they are eating and they titrate their own insulin. And over in our country also, many patients who are pre-gestational diabetic, they have learned this way of managing their own sugar. For prandial doses, however, we see that as the pregnancy progresses, this is a very rough estimate again, because it has been seen that the mean insulin to carbohydrate ratio strengthens over the course of gestation. So 1 unit for 10 gram carbohydrate is in the beginning of pregnancy. Later it can become 1:5. So you may need, for 5 gram, you may need 1 unit at breakfast and lunch and dinner. So it is seen breakfast is supposed to be more, requirement is higher, and lunch time it is, in intermediate dinner it may be lower. So that is what the studies have shown. Now in GDM, which is something which we all manage, and normally we may not refer to an endocrinologist, because pre-gestational normally will be under the endocrinology care also. So this is very important, that we should be able to manage our own patient. So if a patient has come with a GDM who is diagnosed by you, so if she is having fasting hyperglycemia, you can start her basal insulin, that is the NPH. The dose will normally again be titrated up to 0.1 to 0.2 units per kg per day, but start with lower dose and increase gradually. So 2 units for 100 to 120, 3 units for 121 to 140, 4 units for more than 140, and increase by 1 unit for every 10 milligram above the target. So this is how we start for the fasting hyperglycemia. And if her pre-prandial, pre-meal fasting, not fasting, but pre-meal sugars are raised, you will be doing the 7 samples. So then you can add the morning NPH also. And post-prandial, the rough thumb of rule is for 1 unit for every 10 to 15 gram of carbohydrate. That is equivalent to 20 to 30 milligram deciliter above target. So your target is 120. I can take 1 or 2 minutes. If your target is 120 and your patient is having 140 or 150 this thing, you can only give 1 unit, but then you have to accordingly increase as what is the level which you normally, when you are monitoring, you see. So what I have colored here, in GDM, requirement of insulin is roughly half of the pre-gestational diabetic. Target blood sugar, I think we all know, fasting less than 95, 1 hour if you are doing, it is less than 140, 2 hour if you are doing less than 120, mean capillary glucose should be 100, is around 100, less than 100, and nocturnal glucose concentration should always be more than 60. Otherwise it is dangerous, she can go into hypoglycemia. So keep it, we normally keep it at 70 or more. These are the ACOG guidelines, but our own national guidelines diagnose hypoglycemia if it is less than 70, and they don't keep 60 as the figure. So this is the national guideline. I think all of us, especially our students are there, they should all go through it, 2018. Here they tell about pre-mixed insulin, but we remember that these guidelines were made for not only the obstetricians who are in hospitals and medical colleges, but for the primary and the secondary and the district hospitals. So it is for everybody, and they have done a very good job. So they all say that you start the premixed only 30-70, and according to, they stress on the PP value. If PP is more than 120, after 2 weeks of MNT, you can go for 4 unit, 6 unit, 8 unit according to blood sugar levels, and then further keep titrating. After that, every 3 days you call the patient. Then once the insulin is started, they say do fasting and PP both, and then accordingly they titrate it, seeing the levels of the fasting as well as the PP. So this document is available freely. You can download it and read it. So it is, I think, this thing. And monitoring, we do 7 samples till the sugars are controlled. After that, we can do fasting and 1 PP value, so it can be a staggered approach. This is what the recommendations also say, the FIGO guideline, that in the low, all resources should do at least 3 to 4 times a day, but in low resource they say even once a day, but in relation to the meal time it should be specified. You must do the monitoring, but ideally 3 to 4 times, that is 1 fasting and 2 or 3 PP values should be done. So this is the suggested, that do it in pairs. So one day you will do before breakfast, after, before lunch, after. So like this, you know the entire week. This is week 1 and then week 2. So like this, if you will see the pairs, and then after 2 weeks when you review, if out of 3 pairs, 2 pairs are deranged, you know that you have to increase the insulin. So just with one reading, you will not have knee-jerk reaction, because obviously there may be some variation in the diet. Continuous glucose monitoring, we don't have much evidence, but there are studies now that it can be useful in the pregnant woman, but it is only used as of now as adjunct to self-monitoring in patients with poor control. So it is not any standard of care, and insulin pumps also are not standard of care, only used in pre-gestational diabetics. If they are using, you can allow them to continue, but never start new things in pregnancy, because here they say that during the shifting there can be risk of hypo or hyperglycemia and even decay. So hypoglycemia, I think we all know how to recognize. Less than 70 and sweating and all will happen. So always we ask our patient to keep the glucose powder with her, and important is that after taking the glucose, complex carbohydrate has to be taken, like a chapati or a brown bread slice. So to summarize, insulin therapy is the backbone of pharmacological management of diabetes. Requirement increases with the gestational age. Requirement of insulin in GDM is less than half of that of pre-gestational diabetes. So I think I end over here. Thank you very much for the patient hearing.
Thank you, madam, for that wonderful talk, and you have precisely put out what is actually needed in pregnancy. I wanted to ask one question. A lot of obstetricians tend to add metformin in patients who are already on insulin. Do you recommend it? Does it help, or is it worthwhile?
Yes, it can help in decreasing the number of units of insulin. So it can be added. If you are, especially in the obese patients, it is very helpful.
Secondly, when you're planning to start Aspart or Lispro, would you start with regular insulin first, get a dose, and then change over to Aspart or Lispro?
No, that's not required. We can start straight away.
Thank you, madam.
Thank you.
Thank you so much, Dr. Jyotsna.